Looks like we've got people connecting here real quick. All right, welcome everyone. We are happy to have Dr. John Dougherty here with us again today to talk about OPP, which is Osteopathic Principles and Philosophies, and then taking some questions after that. So without further ado, I'm going to turn it over to Dr. John Dougherty.
Hey guys, well, welcome to our Faculty Friday series. I know before we had mentioned out there that Dr. Danto was going to be here, but I'm pinch hitting for him today. So you drew the short straw, right? Got me. Format for today, we're going to go over a little bit of a presentation, nothing very long, and then we'll open it up for questions for whatever Q&A you guys may have. And I will just tell you once we get through this little first part, all questions are fair game. We'll be open to answering anything that you may so choose, okay? All right, so let me share my slides. We'll get this little presentation going. Okay. Got to be smarter than the machine, right? Okay. All right. So first of all, no, that's not the one I wanted. Hey, welcome to our house. This is my background too. And actually, for those of you that are not from the area, today it's a little dreary and overcast. I'm kind of looking out the window, but this is actually our backyard. Not too shabby. And it was probably taken about, maybe 2 years ago at this exact same time. So I often get questions about the area relative to, weather and stuff. So like today, if it was looking like this, it'd be like 65 degrees. There is snow up in the mountains. I think we're predicted to get our first snow up high starting, I think, the beginning of next week. So we may be looking 1 week from now out the window and see this exact image out the building from where the campus is. So pretty cool stuff. Just a point of reference, since I'm nerding out, we're at about 4,500 feet above sea level at campus. And then just as the top of the mountain up there is 11,000. So it's about a 7,000 foot gain between where we are and up there. And it's often we have snow covered mountains, completely white, beautiful, gorgeous. And then we have, just as you see here, amazingly green grass, foliage, everything down here. So that's, if you're not from the area, just a little point of reference. Okay, so our conversation today, we're going to talk about what is osteopathic practices and principles. And, this is something that is near and dear to my heart, and it's really the reason why I went into osteopathic medicine. And hopefully we're going to be able to give you some color on what those initials OPP stand for. And by the time we're done, my goal and objective is for you to have an appreciation of what it means, how it apply to your patient care, and who basically uses OPP as part of their clinical practice once they graduate. And yes, there's our lovely class of 2025 with Dr. Danto in the middle. And that's another shot of those mountains I showed you before over their shoulders. So that is the Wasatch Front. You can kind of see over there to the left. If you're not, again, familiar with the area, you see the Y. It's kind of like right up in here. And that's where BYU is in relationship to our campus. So we're only about 3 miles away. All right, so what in the world are osteopathic practices and principles? Well, you got to appreciate it. You need context associated with when the first ideas around this philosophy were formed. So this is, if you haven't seen him before, this is Dr. Andrew Taylor Still. Dr. Still was a quote-unquote MD. Now, what does that mean in 1860? So in the day, you became a physician under the apprenticeship model. And it just so happened that his dad was also a physician. He was listed as an MD. And they were missionaries. And they went around taking care of different populations physically and spiritually, because that's how you get people to come to church, right? You took care of their physical well-being, and then you followed up with their spiritual well-being. So when you know that, it kind of helps you appreciate and understand some of the perspective associated with the osteopathic philosophy. Now, long story short, Dr. Still had a lot of tragedy happen in his life. He lost 2 wives to disease. He was in the military. He was in the Kansas cavalry during the Civil War and saw more people die of disease than they did from battle. So that kind of framed up his perspective on life. The medicine that they were giving at the time, that what he gave his dad, or his dad taught him to give people, he had this observation that the medicine actually made people worse. Well, if you think of what medicine was in 1860, 1867, right? We're talking about arsenic, strychnine, opioids, things that today and age we wouldn't even think of using. There are some stuff that were valuable, like they did use maggots, and we still, believe it or not, do use sterile maggots, particularly in wound care. But overall, his observation was that when a physician was involved, patients often sometimes got worse. So the only conclusion his scientific mind could come to was that the difference was that physician engaging with that patient. And maybe they would be fine if they didn't have a physician in there. So like I said, his dad was a missionary. And other important things to know about Dr. Still when we start talking about osteopathic practices and principles was that he's what's known as a millwright. And there is a mill being built right there. But technically, a millwright is a discipline in construction that does not use, I should correct me. They only use 7 specific tools. And they learn a lot about leverage. They learn a lot about angles. They learn a lot about force vectors. And just kind of a fun note, my dad was a millwright too. I think maybe that's why this spoke to me so much when I was coming through about where you guys are, because I could completely understand where he was coming from, because my dad taught me some of the same stuff that Dr. Still used. He was also an educator before he started teaching osteopathic medicine. Him and his family in the Midwest actually built Baker University in Baldwin, Kansas. And they made the mill, they cut the lumber, and they built the building. Little interesting story. They chased him out later because they thought he was crazy, but he helped start Baker University. And in today's day and age, we would have considered him to be a disruptive innovator. In the 1860s, he was just considered to be a troublemaker because he questioned a lot of the status quo, if you will, and like the medicine thing. So he came to the conclusion that he was going to not use medicine. And that was completely going against the grain. One of the reasons why he was chastised and why he was chased out was because he was just like, I know we've done this quote unquote forever, but I don't think this is something that I want to do for my patients, and made the promise that he wasn't going to use medicine. And for better or for worse, sometimes there is still the perception that osteopathic physicians do not use medicine, that we only do manual stuff, which I'm going to cover in a second. And this is the basis from where this conversation comes from. So you get to collectively correct someone who says that. And you said, you're right. 150 years ago, they didn't use medicine. But you have to remember, this was before they knew anything about bacteria, anything before about viruses. You guys know more coming out of your sophomore biology class than even practicing physicians and leading scientists of their day knew prior to the turn of the century. All right, so what are these osteopathic philosophy? What's the osteopathic practices and principle? What are the tenets that he framed up around this? Well, first of all, he put forward the idea that the body is a unit. And he noticed that if there was a disruption of that unit, then other parts of the body started going, haywire. So let's take, for example, someone that has an amputation. And that was his point of reference, as a matter of fact, because in the Civil War, if somebody got a wound, what happened? They got that limb cut off. Hence the term sawbones. Sawbones came from the Civil War physicians, the battlefield physicians, of which Dr. Still was one. So when that person, let's say, lost a leg and they were on a crutch, I'm going to exaggerate a little bit, but their body would be twisted to the side on that crutch. And he noticed that those people were more likely to get pneumonia. And then he noticed that it was because maybe they weren't sitting up straight, because they couldn't open their chest wall completely, or they couldn't cough completely. They couldn't get stuff out. So hence his principle that the body is a unit. Everything has to be working together to be successful. The next thing that he noticed was that, let's use the amputation example again, some folks didn't heal as well as others. They got their leg cut off below the knee, and that some people did well and some people did not. And he didn't understand at first what the difference was, but he knew that there was something within those people that did well that helped them get better on their own. He didn't know anything about microbiology. They didn't know anything about immune systems, but he knew something was in there. So he came up with this second tenet, which is the body does possess a self-regulatory mechanism. It can heal itself when given the appropriate opportunity. And by the way, one of his subsections underneath this was that he figured out that that was carried around in the blood because a warm stump would heal, but a cool stump would not. So, he also came up with this, like I said, the sub-philosophy below this was that the rule of the artery is supreme. So he figured out whatever it was in that body that was healing it was in the blood. And that's how we do it. It was direct observational. And then the final one is that structure and function are interrelated. Back to the concept of the person on the crutch. If there is a disconnect between normalized structure, then the function was not normalized. And then there was consequences associated with that. So as a point of that, he figured out to use one of the tools that his father had taught him. His father had taught him to use manual medicine, in other words, manipulation. It's Chinese medicine. It goes back 2,000 years. DOs in no way, shape, or form invented it. And there's always the question, I guess, is this like chiropractic medicine? Well, interestingly enough, the young man who started chiropractic schools, Dr. Palmer, was with Dr. Still in Kirksville, Missouri for a while when he left and went to Iowa to start that medical discipline. And there is a significant amount of value in both. But as a point of reference, that's where that philosophy came from. And again, DOs did not invent it. Dr. Still's dad taught him that, and he used it. And he got pretty good at it. And as a matter of fact, that was his nickname there. His nickname was the Lightning Bone Setter. So he used that tool to normalize structure and function to get the body to take care of itself. And when you don't have any other medicine, guess what? The rate of recovery of his patients compared to other people, again, in the 1870s, 1880s, was significantly stronger than those that were using the quote unquote traditional methods, which we have already discussed. So his first philosophy is that you've got to understand all the above when you're taking care of your practices. Now, I just want to finish up a couple points I have on the slide before I move on. First of all, he was known as an itinerant practice. And what does that mean? Well, that you show him on a horse there. That's what he did. He traveled around. He was a circuit rider, if you will. So he'd be in a town for a few days, then move on to the next town, take care of the people, then move on to the next town, and so on and so on. And that's because the population was a little more decentralized in the day. So he had to do that to make a living and to move around. He did it mostly in and around northern Missouri and around Kansas City, if you will. So there was a point in time when there was a bunch of people that tried to get up against him because they said his tenets were heresy, and actually went to the U.S. Congress where they tried to block Dr. Still from being able to practice medicine. But lo and behold, there was the patient of his that was very well known, Mr. Samuel Clemens. You probably know him by his other name, Mark Twain. And he testified before Congress that if it weren't for Dr. Still, that he would not be enjoying the health that he was. And if it weren't for Mark Twain stepping up for the osteopathic profession, we probably wouldn't be here today. So that's just a little fun fact right there. All right, so let's talk about what is the difference between, what is OPP? So now you got the 4 tenets. And my gosh, what is he talking about OPP? And he's got a surgery going on here. What is the story? Well, let me tell you about some of my friends. And I'll talk about a neurosurgeon, and then I'll talk about an orthopedic surgeon. So when you come to our school, we will teach you this philosophy. Now, the philosophy, remember we just looked at those tenets, right? Our philosophy is essentially the patient comes first, patient-centered care. And it doesn't matter what specialty or discipline that you go into. Our hope and goal is that we instill in you that philosophy that the patient comes first. DOs are a little more social, if you will, when it comes to interacting with patients because we desire that. We like the interaction. And when I said I'm going to give you some examples, so one of my good friends, his name's Dr. Greg Smith. I've known Greg since his first day out of residency. And he will tell you that he is, without a doubt, an osteopathic neurosurgeon. So what does that mean? Does he get in there and does he manipulate the brain? No. What he says is that his perspective is about who is sitting in front of him. He wants to know if he's got a patient that needs neurosurgery, that he addresses her needs as a person. So one, how did she get to the office today? What is her transportation challenges? Does she have food disparities? Is there anything that she needs relative to being able to afford the medication? Who's going to take care of her after surgery? Has she quit smoking because smoking is going to affect her healing? And just as important as all of the above, who's going to take care of her dog while she's in the hospital? Because there are patients you will find who will decline having life-saving surgery because they just don't know what they're going to do with their pet. So that right there is a great example of an osteopathic neurosurgeon. Now, there are physicians who become surgeons who do not use osteopathic practices and principles. And that's not a challenge for us in any way, shape, or form. That's perfectly fine. Because we do have a lot of our MD colleagues. As a matter of fact, the Norda College of Osteopathic Medicine, over half of our faculty are MDs. But every single one of them believe in this patient-centered care. And for that matter, we're very fortunate in the state of Utah to have health systems that also practice that philosophy. Intermountain Healthcare is the largest provider in the region. They now just bought a bunch of hospitals in Colorado. And that's really their central focus. Their CEO is an MD, but he thinks very osteopathically. As a matter of fact, he was underneath the tutelage of an osteopathic physician when he worked at his previous job at the Cleveland Clinic. So there's no doubt in my mind that some of those lessons that he learned in Cleveland have been carried forward here into Utah. And then Mountain Star and Stewart Health, which are other friends in the neighborhood with which we have clinical relationships, are also very patient-centered care models. So we're super lucky to have that not only as our academic philosophy, but has it as the philosophy of our clinical care partners. All right, so I was going to give you the example of my brother who's an orthopedic surgeon. So he just didn't think this was a big deal. He didn't. I'm switching over, if you will, to manual medicine for a second. And then I worked, 85% of what I do is manual medicine. I'm a sports medicine doctor. I'm not board certified in neuromuscular medicine, which is our board certification in the hands-on stuff. But I do, like I said, 85% of what I do is hands-on. So he's seen me, because we were practicing together, use my manual medicine skills a ton and help our patients be successful. So he's actually called me from the ER asking me how to do techniques because he knows it's not surgical, but he wants to help the patient. He wants to get them out of pain. So there's that perspective too. Sometimes you just need to know what it is. And if you don't do it, no problem. Just have someone you know that you can send to help accomplish that part of the patient care. And that will maintain that patient's opportunity to get, if you will, here comes that word, holistic osteopathic care. By the way, I joke, if you say osteopathic, or if you say holistic more than 3 times in an interview, you're out. Just a joke, okay? All right, so next, let's go into this O&M. This is actually the technique that my brother was calling me about. So this is the hands-on part. So our classes are around the support of the osteopathic practices and principles. First course is actually called OPP. It's an introduction to osteopathic medicine. But then the next course that we're doing right now is called structure and function. And after this little talk, you now know why that next course is called structure and function. It's basically anatomy, physiology, embryology, and histology. All 4 of those sciences translate into structure and function. If there's not normalization of those, then we're going to have all kinds of problems. In this example, this is OM&M. So OM&M stands for osteopathic manual manipulation. Sometimes you will also hear the term OMT, osteopathic manipulative treatment. They're essentially the same. Now, there may be some mild nuances, and one term may be preferred over another in different parts of the country. But ultimately, in the end, OMM and OMT are the same. So just to make it completely confusing, we have OPP, OMM, and OMT. And in this example, this physician is accomplishing a reduction of a first rib that's stuck up in the air, and it can cause upper back and neck pain, and sometimes have problems with taking deep respirations or deep inspiration, and it gets stuck, if you will, up. So when you take a big breath in your chest wall expands, right? And when you blow out all the air, your chest wall collapses. Well, sometimes if you have a big breath in and just say, for example, you cough or sneeze, it causes that rib to get stuck. And when you take a big breath and you blow it out, it doesn't go back down. It stays up. So this is getting the patient into a position to which you're maximizing the body's own natural position and helping to facilitate it back into that normal inspiration and respiratory motion. So that's one example of OMM. And there is stuff that's on specifically around the axial spine. So remember, the axial spine is the chest, if you will, the core, the abdomen, and the pelvis. And then head and neck is a separate, and then you have the appendicular skeleton. And we do appendicular basically means the extremities, right? And there's a lot of what we do is in the individual extremities. And if you've played any sports, you guys have basically experienced this at a low level yourself, because before you participate in your sports, you stretched, right? And you loosened up. And you probably noticed that when you did certain stretches, you had a better range of motion. And from my perspective as a sports med doc, range of motion is everything. I want to improve their hamstring length. Why? So they don't pull their hamstrings, right? Want to make sure that there's a balance between their right and their left side so they don't get injured. And you can accomplish this as an intervention many times in people having low back pain or them having shoulder pain. And you can actually physically stretch or manipulate. And in some instances, you're going to get an auditory pop, which that's a conversation for a whole different day. And then they get relief of their pain. We have a lot of studies, particularly in low back, that shows that osteopathic manipulative treatment is very effective compared to placebo in resolving acute low back pain. And that's one of our emphases here, is getting more of that evidence-based studies out into the general population and supporting what we're doing as a profession philosophically and, if you will, in direct patient care. So what else is OPP? Well, this is a very dear friend of mine. This is Dr. Stacy Pierce-Talsma, and that's her husband on the table. And not only is the philosophy of hands-on, but Dr. Stacy is a huge proponent of yoga as medicine. Remember, I was just talking about before in the extremities, when I'm going to, stretch out somebody's hamstrings, minimize their risk. Well, that's kind of an acute intervention. Here we have yoga that is a long-term intervention. We're going to help joint mobilization. We're going to help improve range of motion. And therefore, we're going to what? Normalize structure and function. And what's that going to do? That's going to give the body its own inherent ability to heal itself. Ta-da! There you go. Osteopathic practices and principles. Other osteopathic physicians incorporate things like Tai Chi, acupuncture, cupping, all of those different type of interventions you can use as an osteopathic physician and just apply it as you feel would be the most beneficial for who? The patient, the person sitting in front of you. Because we always treat every individual as exactly that, as an individual. We want them to be the person that all of these different opportunities for intervention, you pick and choose and focus what is the most relevant for their current situation. And that's pretty much the overall osteopathic philosophy. Treating every individual is exactly that, an individual. All right, I just got a couple more slides here, a little more fun, couple stories. So first of all, I mentioned before that I'm a sports medicine doc, and this is my son, and I am with him in the Dominican Republic. And if you've looked on my page, you probably see that I've been a physician now for the Kansas City Royals since 2009-ish. Let's just say that, 8 or 9. I'll lose track. And my interview was basically supposed to last 20 minutes with the Royals. The director of sports medicine flew in. So did their head athletic trainer. And they were supposed to meet with 3 groups that day. And they met with my brother and myself. We were just only a 2-person shop. They were supposed to meet with 2 other extensive, large groups with 12, 15 doctors in it. Well, we were the first stop of the day. And when the director of sports medicine came in, they had ridden a smaller plane and he had sat funny. And he walked in kind of walking, if you will, cattywampus, definitely and obviously in discomfort. And so we started the interview and I said, hey, would you like for me to fix that? And he goes, what do you mean? I said, well, your hip. Do you want me to work on that and get it straightened up for you? He goes, you can do that? I said, sure. So got him up on a table, worked on him, got everything all straightened up. And he stood up and he's, oh my gosh, the pain is completely gone. And they never made the other 2 interviews. Those people were calling our office wanting to know where in the world they were. Did they miss their flight or what it was? Like, no, they're still here. So because it's a 100% direct result of my knowing my structure, knowing my function, and being able to apply the manual medicine associated with osteopathic practices and principles that got me the job all those years ago, being a team physician for the Kansas City Royals. And I'm glad to say that I'm still part of the team. I am considered to be a biomechanist, which goes directly in relationship to the millwright background, right? And my O&M. So I can identify if there's a problem with an individual that could potentially cause them to be injured before they get injured. And that's one of the reasons why they've kept me around so long, even though I'm clearly not in Kansas City, I'm in Utah, and I'm not around any of their minor league clubs. So my job with them is what you see here before you, is I am a caregiver for the team in the Dominican Republic. And I go there 2-3 times a year, and we take care of the athletes down there and evaluate them, give them protocols and therapies to make sure that they don't get injured and hopefully make it over to the major league side. So, and with that, that's all I had prepared for formal today. And I think we've got about 25, 30 minutes left. So I use up half my time. Let's open it up to any questions. And everything is fair game, you guys.
And if you're with us on Zoom, go ahead and drop your questions using the Q&A function. And then if you're watching on Facebook or YouTube, just use the chat function. And we have people monitoring all of those, watching for questions. And while we're waiting for a couple to drop in, I have a couple of questions for you, Dr. D.
Yes, ma'am.
So can you talk a little bit about how much time Noorda-COM students spend learning and practicing OMM, OPP stuff?
Yes, ma'am. So in the curriculum, the very first course is called Osteopathic Practices and Principles. And embedded within that first course is a little bit of a higher level of appreciation for these techniques and for the structures that we just mentioned. By the way, before you start with us, we have a summer course that we offer for all of our accepted students at no charge that allows you to review anatomy and a little bit of physiology. So when you come to campus, if you've never had a day of anatomy in your life, you'll have had an opportunity to get an initial introduction over the summer. And if you had it like your sophomore year, you get a good opportunity to knock the rust off. So that is within the first course, but also within the first course is osteopathic principles around the patients, such as food disparities and at-risk populations. So in the rest of the world, they call those health system sciences and public health. It's just part of who we are and what we do. So within a regular schedule, so let's look at a 2-week schedule. There is, that's what our cycle is. So you do the education and the learning pods for 8 days. Then we have our review sessions on Thursday and Friday. The last 2 days have been review days. And over that 2-week cycle, you will have 2 times to where you will go into the lab with faculty just to work on this structure and function skills. Now you have another time or 2 to where you're going to learn physical diagnosis or communication skills. And to us, all 3 of those are blended together: communications, physical diagnosis, and manual medicine. Because like I mentioned at the beginning, they're all tied in together. So after the first course, which just ended about 2 weeks ago, so that first course is 8 weeks long, you will spend probably, if you will, the equivalent of an hour of lecture time. So that may be 4 or 5 videos a week. And then you will have an hour in the hands-on labs with the faculty. And so I'm helping out on Monday afternoon. Let's give an example. The lab's 3 hours, but students sign up for 1 hour blocks. And so there's 3 different groups of students that come through over that 3 hours that we're in lab. And that allows us to keep our student to instructor ratio really low. It's about 8 to 1. And then that way, you know that you've got direct hands-on and that you are being successful at the skills that you're learning. Like we like to say, competent and confident. And so you're not just lucking through and just putting it like in the rearview mirror, because it's something we want to build on. So to summarize that long answer to a short question, Kristen, over a 2-week period of time, with just OPP alone, you're probably looking at a total of probably 5 hours in a 2-week period of time.
Awesome. Okay, and you mentioned the labs. Can you talk a little bit about the structure of those? You said that students are there kind of for an hour. Are they just like practicing and passing off the techniques and things that they're learning in a given cycle or week?
So very similar to the rest of the content, we pre-record what the exercise or what the activity is going to be for that week's lab. So you do have an opportunity to watch it ahead of time. And we have a session to where you can come in and practice. We have open lab. And then when you feel competent and confident, then we sign off on your skill and say you're good to go. And then we do have a longitudinal assessment associated with these hands-on skills. And if you're familiar with the term OSCE, which is Objective Structured Clinical Evaluation, it's combining all of these skills together. So you'll have that assessment at the end of the first year. And I think it's 2 times in the first year and 2 times in the second year, to where you combine your skills about communications, patient interaction, physical exam skills, and then incorporating manual medicine with that. And in those scenarios, you're talking through it, because obviously you can't have the same standardized patient have the same problem, 12 times in a row.
Awesome. Thank you. Okay. And also you mentioned things like yoga, acupuncture, and cupping, and some other various things. Are those things that are incorporated into the Noorda-COM curriculum so that our students leave knowing some of those techniques and that sort of thing?
We have faculty that have plans for making those electives. Now, a little bit about a curriculum, if you haven't watched that discussion. First of all, we have core content. And core content is material that is, going to be on boards. And so we make sure that everyone gets exposure to those efforts. Now, cupping, acupuncture, and yoga are not on boards. But like I mentioned, it is a complementary, if you will, tool associated with osteopathic practices and principles. So we have faculty that, depending on the discipline, have a strong interest in providing those experiences. We actually have a community physician who's very well known across the country for acupuncture. And we're talking to her about having her come in and teach an acupuncture course. She's a DO. She works at a company close by, and she loves teaching people about acupuncture. So that will be elective content that you may choose to take, but not everybody has to learn those skills unless they choose to.
All right. And just a quick reminder that the Q&A is open to anything. I'm just asking kind of OPP targeted questions, but you guys can ask anything that you want. It looks like we just had a question come in. So what markers are used initially to know that a student is accurately performing the OMT?
Well, we start off slow, right? Because it's not like your first day you learn to drive, you're gonna drive NASCAR. Although maybe you will, I don't know. Just depends on you. So there are specific observations that we make. And we have, if you will, a rubric or a checklist that we watch and make sure where you put your hand, that you know why you're doing what you're doing, and that you position the patient correctly. Like that one I showed you of them doing the first rib, you need to know how to get them in that exact position successfully. And then once we move closer into third year, because it's actually not until third year when they're out in the hospitals. By the way, we bring students back and work with these on these OPP, O&M skills continually through their third year. We'll work on techniques that you will actually go and do the next day in the hospital, the next week in the hospital. A classic one is that there is a technique that we can have you do on folks that have come out of surgery that helps them get their bowels to wake up. Because if you don't know, anesthesia puts your bowels to sleep too. And sometimes your gut doesn't want to wake up. And they won't let you leave the hospital till you pass gas. So one of our really well-studied osteopathic manipulative intervention is working on the belly, helping to wake up the gut. And you're going to have the absolutely fabulous normalization of function called tooting. So every mom that's had a baby knows what that means. You got to, before they'll even let you out the door, you got to pass gas. So that's kind of how we assess it. And again, it depends on what level we have. First years expect at a beginner level. Second year is intermediate, and once we get to third, we start getting more towards the competent level.
Awesome, thank you. And you kind of touched on kind of one area, but can you share maybe some other specialties where OMM is used? Logan says, I often get told OMM is most useful for only primary care specialties, but can you talk about how specialists might use OMM a little bit more?
Sure. So the surgery example I just gave you is a clear one. There's some specific techniques in OB, particularly for moms towards the middle or the end of their pregnancy, because, nothing gets jacked up when you got, a big 9-pound somebody in your tummy. So there's OB is a huge area where there's an opportunity for OMT. Then orthopedics, very clearly, because just because somebody has pain, you get called to the ER, doesn't mean that they need a surgeon. PM&R, physical medicine rehab, is another really big area. And by the way, this is becoming a huge growth area as it focuses on structure and function. And there's a lot of nutrition involved with that as well. Obviously, sports medicine, what we do, depending on, what you do, it's, for me, like I said, it's 85% manual stuff. For some folks, it could be as little as 25, 30%, but we have DOs who are head Olympic physicians. I have a physician who's over the WWE. I've got friends and colleagues at a ton of Division I schools and professors around the country, and they're there because of these skills. And then family practice uses it quite a bit. And there's family practices, doctors that don't use it at all. It's perfectly fine, whatever is their personal preference. So peds, we have actually one of our faculty members did a pediatric residency and then a fellowship at O&M. So she uses it a lot in peds. So that's probably the big areas off the top of my head. And as you can see, that's a broad across the board spectrum. And by the way, just like I mentioned before, if you don't, you send it to somebody. We have consultation services in the hospital, and we have specialists from cardiology, GI, neuro, everybody. When they recognize that there's a problem with the structure and they are not sure, they consult us. Just like I have absolutely no idea how to catheterize a heart, but I know my patient needs a heart cath. I'm going to call that interventional cardiologist to bail me out. Same way, hopefully, and they've called me when they've got somebody because they've laid on that table in the cath lab so long and stuff gets stuck. Well, I've gone in and I've helped motion, and then their patient feels relief because it was just the position they were in. So lots of give and take between the disciplines on that.
Awesome. Thank you. All right. Sudeep says, I would like to know how much the osteopathic principles and tenets are incorporated into the curriculum for basic science classes, and how kind of those mix and mingle.
Sure. So like I mentioned earlier, structure and function is going on right now. And that is a huge integration. Anatomy, clearly. You have to know your anatomy. You have to know your physiology. If something's not working, you need to understand why and what you can do to quote unquote normalize function. Even biochemistry, if you know what normal pathways are and how pathways can go sideways, that is intervention. So, and then the next course that we have after Christmas break, winter break is called inherent abilities. Remember, he said that your body has an inherent ability to self-regulate. Inherent abilities is microbiology, immunology. We even start sprinkling in pharmacology because, yes, DOs do use medicine we do surgery all the time, but we want you to appreciate what it is that you're accomplishing with the pharmacology. So even the chair of our biomedical sciences department, he teaches pharm, and he will tell you, hey, you need to know where you need to apply pharmacologic agents at the appropriate moment to help get that person over the top so they can normalize it. It's all about patient-centered care. So every single biomedical sciences is incorporated into osteopathic practices and principles. Now, something else that we do weird, most schools either stop at the first year, and then that's the last time you see a biochemist. We actually move biochemistry into the second year and into the third year, just for that exact reason, because they need to appreciate what it is in that biochemical pathway that's either making that drug work or that's keeping that person from getting better. And so we, as I like to say, vertically integrate all of our biomedical sciences into the clinical sciences all the way into the hospital with you. So for us, it's all the above. Not all schools do that, but we sure as heck do.
Awesome. Thank you. Okay. Udisa has a question about opportunities to perform OMM on patients in hospitals during like the third year rotations, and whether or not there are designated times similar to how there's learning pods to practice OMM techniques that are taught. And we kind of touched on that with the labs. Mm-hmm. And then also, do Noorda-COM students practice on each other? So lots to unwrap there.
That's good. That's good. Yes, they practice on each other. We have portable tables. Some of them already have their own tables. By the way, we're just getting our clubs and organizations up and running. So it's usually, there's one club in particular that usually, sponsors getting everybody portable tables, gets you at a good discount for that. So that happens. And again, being our first year, we may be a couple of days behind on schedule on that. But yes, they do practice on each other. Yes, they do it in lab. Yes, they do it outside of lab. And then as far as the hospitals, on each of your evaluations, there is a question to the faculty, whether they're MD or DO. One, did you suggest osteopathic interventions? It may be a manipulation. It may be a patient-centered care type of idea. So you're assessed by that. And then we are having, again, we're just getting everything started. The plan is for us to have an inpatient OPP consultation service. And there's a hospital just by us that we have a lot of solid relationships with that they're interested in that. So by the time you guys get here up and running, we would indeed have an inpatient service. If you're with a DO who is in the hospital, we have, for example, Utah Valley Hospital is 3 miles away. They have a family practice residency there. Over half of their family practice residents, if not more, are DOs. The sports medicine fellowship is there too. I teach osteopathic manipulative medicine, not just OPP, but specifically OM&M to those fellows every year. So they're using it. So our neighborhood has a really open mind. And Utah, you will find if you're not from here, if you're from here, you'll give an affirmation to me, but they have a lot of curiosity, if you will, about things that just aren't the status quo. It's a very entrepreneurial environment. It's a very open-minded environment. And if you say, hey, I think I can make your neck stop hurting if you just let me do a little thing, trust me, they're going to be like, go, just do it. So as opposed to other places where you're going to receive maybe some skepticism because of maybe some long-standing preconceived misconceptions that nobody's ever really had the opportunity to talk to them about. So yeah, all the above. It's super fun.
Awesome. That's exciting. All right. One more question here from Rajbir. So you mentioned OPP, including concepts like food disparities and serving underserved populations.
Yes.
That are typically included in the public health sciences. Are there opportunities for students at Noorda to tackle these problems in the real world through like a student-run clinic or other similar organizations?
Yeah, that's a great question. Yes, we do. Matter of fact, right after I get done with this, we're having our first student government meeting. And from that, it will just explode. One of my favorite things about Utah County is that we have, if not the most organized, one of the most organized United Ways anywhere in the country. And of course, they're already in the community doing a fabulous job helping address some of those needs and shortages. And we won't have to reinvent the wheel, if you will. They have opened their doors to be a partner of ours, and we will have their infrastructure in support of all of our clubs and organizations to identify at-need communities, to identify opportunities, and to integrate additional resources beyond the student body to help meet those disparities. So we're pretty excited about that. Again, one of the unique things about our neighborhood, kind of like the mountains behind me, pretty special group over there.
Yeah, lots of really cool opportunities here.
Oh, yeah.
All right. One more question here from Sudeep. So you mentioned the importance of publishing evidence for the benefits of osteopathic medicine. Will there be opportunities to do that kind of research at Noorda-COM?
Be careful what you wish for. Yes, we actually have our 4 research houses. If you haven't watched that Faculty Friday, I encourage you to do so, or do a little cyber stalking on our website. We have 4 research houses. And one of which is kind of dedicated to this. It's included in, well, it's across all, the philosophies across all 4 houses, but in particular, the pain and addiction house. I tried not to be Harry Potter houses, but they just kind of identify themselves as Slytherin, go figure. But that already, the team of faculty primary investigators in that shop are just concluded a study where they proved that, in particular, manual manipulation of the cervical spine helps to decrease the desire for alcohol in recovering alcoholics. First time ever it's been proven. And we did that not in people, ironically enough, but we did that in rats. And those rats have a little party, and then they get them addicted, and then they've been doing manipulation on them. And then we actually have the part of their brain that does pleasure and pain wired. And we've proven that we decrease the stimulation of that with the manipulation. So that's part 1. And there is dozens of chapters to follow that. So if that's something you're really interested in, we have the right people and the right tools and the right relationships to make that a big success for you.
That's just crazy to me.
So
super exciting, especially for someone like me who came from a background working in substance abuse treatment. To know that there's something so simple that makes such a big impact is just crazy and exciting. I can't wait to see where we go with that. All right, Rima has a question. In general, how do you approach patients and discuss that there is a hands-on approach to treatment rather than just treating with medications? This is probably a pretty big issue nowadays where, as Americans, we want a pill. Quick fix.
And I was just on the phone with one of our local congressmen yesterday, and this was exactly one of their questions. How can we accomplish this? So again, we're very fortunate to have very like-minded clinical partners. And having that conversation, just what you just said, is probably the most important part of the outcome is talking about it. And we've always talked about how there's a stigma associated with mental health, right? That's been out there for a while. It's really starting to turn the corner on that. We need to do the same thing in addiction. We need to have the conversation about the point of entry into an addictive pathway and what can we do different. So this congressman was specifically asking, he had surgery and he didn't want a narcotics prescription, but he knew me and he knew that we could do stuff that would help minimize his pain and help his recovery. So that's how the point of division associated with narcotics or another type of therapy is where we're going to be focusing on beginning that conversation. And I think that if we accomplish that, then we'll start just like 10, 12 years ago when folks started talking about addressing behavioral health as a disease, not a one-off. That's the same thing I think we're going to start having a point of intervention. And I really think we're going to be at the tip of the spear on that kind of an opportunity.
It's exciting to be a part of this and watch it all unfold. I'm excited to see where we go. I think we'll do crazy, amazing things here. So, all right, it looks like that covers all of the questions that have come through. Do you have any parting words for our viewers today?
I would say you don't have to go into an interview or you have to go into a shadowing thinking that you have to be all in when it comes to O&M or OPP. I would say for OPP, if you find yourself thinking about the person in front of you, then we're probably a good fit. Lots of people, like 80% of our students, come through and don't actually use the manipulative medicine, but they all use the philosophy. If it's something that excites you and you're like, man, that is a tool I want in my belt, then we're a really good spot. There's a lot of good DO schools that do excellent on training the hands-on skills. But I like to think that we may, as you've heard here today, hopefully come at it with a little different perspective and with a little more global conversation about that person in front of you. And, if you're not all in, please don't think, oh my gosh, this isn't for me. Because you never know. It may be, it may not, but still, if that patient is who you want to take care of, give us a call.
All right. Thank you for your time, Dr. Dougherty, and jumping in to take over this for Dr. Danto at the last minute for us here today.
My pleasure.
And thank you all for being with us here this week. As a reminder, we're here almost every Friday. Next week, we will have a week off, but then we'll be back the following week on Friday for the next Faculty Friday session. As a reminder, you can register for all of these sessions on our events page, which is Noorda-COM.org/events. And if you've missed any of the previous sessions, like, for example, the one that Dr. Dougherty mentioned about research and diving into the research houses, you can find the recordings for those on our Facebook page, on our YouTube channel, and then they're also linked on our events page as well. So again, we thank you for being with us today, and we'll see you back here in a couple of weeks for the next Faculty Friday session. Everyone stay safe, and we'll see you